Alright, welcome to today's class. In this video, we will talk about progestins. Now, what are progestins? They are progesterone-like drugs. They are drugs that are derived from progesterone and they act like progesterone. So, in fact, progesterone is a natural progestin. Progesterone is a what? It's a natural progestin. So, we'll start with the first one, which is natural progestin, basically progesterone. Then we'll move to synthetic progestin. Then we'll talk about their uses. Okay. Now, progesterone is the most important progestin that I want you to take note of. It is the most important progestin, and from progesterone you can get the other hormones. The other hormones you can get them. For example, from progesterone you can get estrogen. From progesterone you can get your androgens. From progesterone you can get your adrenal corticoid hormone. Okay, so it's more like after you start with cholesterol, the starting molecule is always cholesterol. From cholesterol we will get pregnenolone. Then from there we will get progesterone. Then this progesterone will not divide into all these three. It's from progesterone you get estrogen, you get androgens, you can also get your adrenal cortical hormones. All right, so that is very, very important. I like to tell you that sometimes progesterone can also act on these receptors, on estrogen receptors, on androgen receptors, can compete with those receptors. Okay, so now where is this progesterone synthesized? Progesterone is synthesized mainly in the ovary and during pregnancy in the placenta. In the ovary, the particular place where it is synthesized is your corpus luteum during the luteal phase of the menstrual cycle. Okay, during the luteal phase, that's when it is being synthesized. In short, progesterone in the amount of progesterone in a female and that in a male, they are almost the same thing. It's just small difference during the follicular phase. The menstrual cycle has follicular phase and also have luteal phase. Okay, so now the during that follicular phase, both male and female they are almost equal, just that the female is slightly higher than the male. However, once we get to the luteal phase, the progesterone in the female will rise faster. You get progesterone will rise faster, and again it will approach its peak during the third trimester of what? Of pregnancy. During the third trimester of pregnancy, that is for progesterone. Now, what do you think we use progesterone for? What do you think is the main use of progesterone? What do you think is the main use of progesterone? So, the main use of progesterone is that it helps to what? Or the physiological role of progesterone in the body. Before we talk about its clinical use, it helps to what? To prime the uterus. It helps to like make the uterus secretory in nature so that the incoming fetus can implant properly, or the incoming embryo can implant properly. So it prepares the uterus for the incoming what? Fetus. Okay. Now the estrogen is to what? Is to make the uterus proliferate. Why it is progesterone that will make it what? Secretory, so that the embryo can what? Can implant. All right. So that is the main rule. Apart from that, progesterone also has other rules. It also has other rules. I will just list them here. Progesterone tends to like it has metabolic rule. It has what? Metabolic rule. It helps to increase basal insulin levels. It increases basal insulin levels. So let me just put it down here. Increases basal insulin levels. So basal insulin levels. Okay, it increases your basal insulin level. That's why in pregnant women you notice that their insulin levels is high. Then also progesterone tends to make your respiratory centers more sensitive to carbon dioxide. So that will lead to what? More deeper breathing. And by so doing, if you measure the arterial CO2 in a pregnant woman, you will notice that it will be low as compared to a non-pregnant woman. Okay. Also, progesterone, in terms of its physiological function, it also what? Has effect on body temperature. It tends to increase body temperature. However, the mechanism for that is not yet known. And lastly, progesterone competes with aldosterone in mineralocorticoid receptors. That's why you notice that it will, when you compete with aldosterone, it means that you will now have low amount of sodium. You get, because aldosterone will not be able to reabsorb sodium, and by so doing, more aldosterone will be released. That is why in a pregnant woman, you will notice that there is more, the levels of aldosterone is high. The levels of what aldosterone is higher compared to a non-pregnant woman. So these are just few roles of progesterone, but the main one, the main physiological role of progesterone is to prime the uterus. After estrogen has make it proliferative in nature, progesterone will come in and make it what mature and secretory, so that the embryo can easily what implant in that uterus. That's the main function. Now, I haven't talked about synthetic, the natural progestins. Let's talk about the synthetic ones now. Now, your synthetic progestins are derived from either the 21 carbon molecule or a 19 carbon molecule. The idea is that progesterone is usually 21 carbon. If you count the numbers of carbon in the structure of progesterone, it's 21 carbon. Okay, so now these synthetic progestins, it means that they are synthesized from progesterone, right? They are in a way manufactured to look like progesterone. Now, if you manufacture from a 19 carbon, it will look more closely like the natural progestin, which is progesterone. What am I trying to say? I'm trying to say that the 21 carbon molecule is more closely related to progesterone as compared to the 19 carbon molecule. And take note that the reason why we are even talking about this synthetic progestin is because there's a limitation of the natural progestin. The natural progestin, they have high first pass metabolism. You get, so you can't give them orally. Okay, so that's why we are talking about, oh, let's make some synthetic progestin that we can also administer orally to patient and aid compliance to the drug. All right, so I said that your synthetic progestins could either be derived from a 21 carbon or a 19 carbon. If it is derived from a 21 carbon, it will resemble the natural progestin in many aspects, especially the aspect of acting on mineralocorticoid receptors. You get, but these 19 carbon derivatives, they can't act on, they don't have any effect on the mineralocorticoid receptors apart from a few exceptions, but majority of them does not have any effect on the mineralocorticoid receptor. Now let's look at the 21 carbon derivative. 21 carbon derivative include things like a what hydroxyprogesterone. You can see the word progesterone is inside. The only difference there is just they add hydroxy. You get my point? We have what medroxyprogesterone, we have megastrol, and dimethensterone. Okay, all these ones are your 21 carbon derivative, but the one I want you to take note of is hydroxyprogesterone and medroxyprogesterone. Take note of them. Then maybe you can also add this one also, megastrol. All right, there are 21 carbon derivatives of what of progesterone, and they resemble the natural progesterone in a large extent. Okay, and the main use of these guys, later on we'll get to realize that the main clinical use of progesterone is again two things: one as hormone replacement therapy, and two as contraceptives. So these ones that look like progesterone are the ones we use as hormone replacement therapy because they are more closely related to progesterone, and we just use them for hormone replacement therapy. However, the 19 carbon derivatives, which are the newer ones, they are majorly used for what? They are majorly used for contraceptives. So that is one distinction between them. So I'm trying to tell you that we have two main types of synthetic progestins: the 21 carbon derivatives and the 19 carbon derivative. The 21 carbon derivatives are mainly used as replacement therapy in postmenopausal women and other cases. But these 19 carbon derivatives, they are mainly used for what? As contraceptives. The 19 carbon derivatives are further divided into generations, and each generation as as you go down the generation, there's increasing potency, and again there's decreasing androgenic activity. Remember I told you at the beginning that progesterone acts as a precursor for the synthesis of the other hormones. It acts as a precursor for the synthesis of estrogen. It acts as a precursor for the synthesis of androgens. So it will not be surprising that some progestins will have androgenic effect. That's why when you give this, for example, when you give this non-eating drone to patient, and they have this androgenic activity, it will lead to what? Ink. The ladies will start having inks, they will start having a citizen, so those manly features will start coming out. You get that is the limitation. So the first generation derivatives are what? Is strains. These strains include non-ethindron and linesterenone. Linesterenone. Okay, these are the two first generation, and they are called strains. Now, one thing about them is that their potency is low. That is one, and they have high androgenic activity, meaning they can act on they can act like androgens, acting on androgen receptors, and that will lead to ink and hirsutism and manly features. Okay, imagine now you are giving this drug to a patient for contraceptive. Now the lady is taking this drug. She now notices that she's having inks. She like her skin is rough and things like that. Compliance will be poor. Okay, so that's why we now move to the second generation. The second generations are called gonins. Now these gonins include non-gestural and levogestural. So once you are talking about gonin, one thing you always see in gonin is this jest word. This jest word. You always see jest word in what? In gonins. Okay. So again, if you notice, the potency is now increasing. Like I said as you go down, you notice that the potency start to increase, and the androgenic activity tends to what? Decrease. So this second generation gonin, non-gestural and levogestural, they have low androgenic activity but increase what? Potency. Okay, so we still use this one as well hormone as contraceptives also in combination with estrogen. Okay, now the third generation, again the third generation are also gonins, but this time around again you can see the jest word here, right? You can see the jest word. You can see the jest word. Desogestrel and non-gestimate together with gestodone. Now if you notice these ones, in fact this particular one here, this particular third generation, we usually combine them with estrogen. We usually combine it with estrogen in contraceptive pills. Okay, again their potency has increased, but they have what? Zero androgenic activity. So when you give this drug to the patient, those ink and the other things, you will not see them again. The patient will not experience those things, and the patient compliance with the drug will increase. Now, what about the fourth generation? One thing about this fourth generation is that again they are gonins, but this time around they are antagonists on that receptor, meaning that they will not only have. It's not that they will be zero, unlike this third generation that will not even affect the receptor at all. But this fourth generation, they are antagonists in that receptor. It means that you can use them to treat ink. For ladies that are having eggs, citizen, they will antagonize the androgen receptor. So they can be used for the treatment of inks, right? So, and you can also use them as contraceptives also. Okay, so we have nomegestra and drospirenone. This drospirenone is similar to, I believe it's similar to the structure of spironolactone actually. Then this drospirenone also have anti-mineralocorticoid receptor, anti-mineralocorticoid activity. So you can see again, it's not acting like the natural progestins, the natural progest, which is progesterone. No progesterone has anti-mineralocorticoid activity. Okay, so this is everything about the progestins. Again, I said progestins are progesterone-like drugs, and we have the natural one and we have the synthetic one. The natural one is your progesterone, and I said that is the most important one because it is from progesterone you will get the other sex hormones, basically estrogen and the androgens, even your mineralocorticoid. Okay, you understand? Then we talked about the effect of progesterone, where it is synthesized. We talked about that there's a limitation on progesterone in the sense that we cannot give it orally, so we talk about let's go to synthetic progestins. Synthetic progestins, now there are two main word family. And then also the 21 carbon and the 19 carbon. 21 carbon are very closely related to natural progestins. Then also, but your 19 carbon, they are different from it in the sense that they tends to have more androgenic activity and the rest, you get, and they do not have this mineralocorticoid activity apart from, they do not have this anti-mineralocorticoid activity apart from this fourth generation. It is this fourth generation that has the mineralocorticoid activity. However, that all the 21 carbon derivatives, they have this anti-mineralocorticoid what activity. Take note of that too. So that is for that. Shall let's just proceed and talk about the uses. What are the uses of this thing clinically? What do we use them for clinically? So let's talk about the uses. Okay. So the uses of what? Progestins. What do we use progestins for? Like I said, there are only two uses. See that you are using them as hormone replacement therapy, or you are using them in contraceptives. Now, like I said, which of them do you think you can use for hormone replacement therapy? I said is about the 21 carbon derivatives. So your 21 carbon derivatives are the ones that you can use for hormone replacement therapy. That are the ones we use majorly. While for contraceptives, the ones we use are the 19 carbon derivatives. Okay, now 19 carbon derivatives. Those your medroxy, progesterone. Okay, medroxy, progesterone. Okay, medroxy, progesterone, they are majorly used for hormone replacement therapy, while the 19 carbon derivatives are used for what? For contraceptives. Now, apart from that, if we should give, particularly this medroxy, progesterone, if we should give it in high dose, it can lead to what we call ovarian suppression. It can suppress the ovary. And once it suppresses the ovary, we can use that to our advantage in certain conditions that depend on that as a pathophysiology. For example, endometriosis. Endometriosis depends on the more the ovaries are working, producing estrogen and progesterone, the more the likelihood of growth in endometriosis. Okay, endometriosis is a condition where you begin to see uterine tissues outside of the uterus. Okay, so and what causes that is because of excessive growth of the uterus, right? So if you can suppress the ovary, which normally produces the estrogen and progesterone that are acting on the uterus, if you suppress the ovary, endometriosis can be curtailed, can be maintained. You get, and so we give this drug in high doses to cause ovarian suppression. Okay, but however, there's a caveat to that too. If the lady said she wants to give birth in the near time, you don't give this drug, because after the use of this drug, the ovarian suppression will remain for a long time. Okay, so that's one thing to take note of. Then again, apart from endometriosis, stay under this ovarian suppression. We can also use them for abnormal bleeding. We can also use them for dysmenorrhea, that is painful menses. Okay, so those are some of the uses we can use them for. So thank you very much. In the next video, we'll continue from androgens.